Hello, my name's Hope Frost and welcome to this Engaging Your Patients and Delivering Diabetes Clinic webinar. On behalf of the team at SVK Healthcare, I'd just like to say how proud we are to have produced this event, and we do hope that you find it useful. It's now my pleasure to introduce the webinar leader for this session, who is Dr. Jackie Elliott.
Welcome to everybody. Thank you for taking time and trouble to join. Let's kick off. So just to let you know, I have a dual responsibility. So I work at the University of Sheffield, and obviously more recently I've spent a lot more time working as a diabetes consultant. It's meant to be half and half, and I've been an exec member of the Daphne board for quite some time now, and more recently I've taken over as chair of the Daphne group. So Hope asked me just to talk to you about how we've been using some of the technology to remotely support our patients during this time. And the things that we thought might be helpful was just sharing with you some ideas about how we've used and encouraged patients to share good, accurate data, how we've gone about delivering some of our clinics, and also the impact of using electronic patient records, because that's been really positive during this time. We've also set up a Drivethru blood service. We're going to talk a little bit just about how we're trying to upgrade people on pump therapy, also a little bit about remote foot clinics, and then a few words about how Daphne is trying to move forward and adapt the way in which it can be delivered. So in order to get accurate data from patients, we in Sheffield for many, many years have used DiaSend, and this has been great in that we get readings directly from the blood glucose meter, and as soon as we went to telephone clinics, we suddenly thought, oh, we're really missing this data. And so we put together a PDF, and it is specific for Sheffield, and I guess it will be specific for your regions because you know what kind of meters your patients have access to. And it also depends on what kind of technology they've got. So some patients do have a computer, some only have a tablet or a smartphone, so effectively don't have a USB point, and so that can be a little bit limiting. And then there are patients that don't have a computer or a smartphone. And so with these instructions, we went through, well, if you've got a computer, please can you try to create a DiaSend account? And we used the PDF that was on the DiaSend website, and we just adapted it so that we put in directly the Sheffield clinic code, and so that there could be no confusion about who they were sharing their data with. And then depending on the different meters, we let them know how they could upload to DiaSend and whether they needed to ask for a cable or any extra equipment. For those with a tablet or smartphone, again, it depends on which meter you're using. With some of them, you can use DiaSend mobile, and then it gets the data into DiaSend. For others, they have Bluetooth, and that can be good because then they produce reports actually within the meter itself. And then we say, please, can you email us that report? And we've given them a generic email to send their information to, asking them to put in their name and unit number or NHS number into the subject of the email so that we can quickly attach it to their electronic patient record. For those that don't have a computer or a smartphone, we said, don't worry, we still want to know what your glucose readings are. And we sent out just a simple A4 sheet and said, please just record all your glucose day by day. And then this will really help when somebody phones you, and you'll be able to read these results out, and we'll be able to transcribe them very quickly. We're quite a big pump service here in Sheffield, and we realised, well, we also need to download pumps as well as the glucose meters themselves. And so for different pumps, we've given different guidance. And again, we've just made that very specific to the pumps that we use, but some pumps are very easy to plug in, like Omnipod and Tandem can directly go into a PC. Whereas for the Roche system, you do need a smart pix, and you might or might not need a cable as well. And so we actually took photographs of exactly how you need to line the pump up to the smart pix, etc., so that there could be no confusion about what they actually needed to do, trying to make it as easy as we can for patients to share their data with us. And with some encouragement, we're getting some good results with that. So each day we have more and more people saying, oh, I've managed to upload my pump data, please would you have a look. And then we've actually found that this does have a knock-on positive effect. So compared to when before they'd come into clinic and we'd download the meters, when they've actually taken the time and trouble to download the meters themselves, quite often they've looked at the glucose readings and said, my problem appears to be before tea, I wake up with glucose okay, it's okay at lunchtime, but then before tea it starts to rise. And so sometimes you're actually starting the conversation a little bit further on than you would do normally. And it's always a nice surprise when I think we all have, try not to, but we all have a few preconceptions sometimes about which patients might upload. And one of the gents that hadn't uploaded, but I said, you know, could you? And he went, oh yeah, of course I could. He said, I just didn't read the letter properly. We've invited everybody to upload, but he just hadn't read it. And within half an hour, he's got his data on DIASEN and said, you know, has the plan changed? And I said, no, please carry on with that plan. But do email me again in another week and I can have another look at your readings. And then there's some people that actually need a bit more hand-holding. So I pretend that we actually have a tech team. We didn't have a tech team a few weeks ago. What we've done is identified 2 or 3 individuals that are not allowed to have direct patient contact, but they're very good now at talking to people over the phone and trying to get them connected with their different meters and things. So we're trying to formalise that approach more and more to enable more people to share their readings with us. And this has been really helpful kind of in tandem with something that we did a few years ago, and that was to go electronic. So here in Sheffield, for all the diabetes consultations, we've been recording everything about the consultation within System 1. And it varies up and down the country, but in Sheffield, that's about 80% of the GP practices who use System 1 day in, day out. So what are the advantages of that? Well, it enables you to look into the patient record. So as long as they have consented, then we can look at all the entries that the GP has put or the community district nurses. We can say exactly what they've said and when they said it. So there's a complete, it's called a journal, but basically it's a diary of all the events. The other advantages are that the GP blood results go directly into System 1, and so we can see blood tests that the GP has done. We can see all the GP prescriptions. We can see the list of current comorbidities that the GP has recorded. And then also within that system, we can get limited information from the EMIS practices. So this tends to be the other big system used within the UK. And we can still see prescribing data, a problem list, and we just get the last 3 diary entries that the GP has recorded. We've also made sure that we've moved now into going electronic as far as we can with referrals. And as clinical lead for diabetes in Sheffield, I said, oh, I'll take on that job because previously it was split between various people and was paper-based. And so now I'm just reviewing all the referrals electronically, and then that enables me to assign the referrals to the right professional groups. So sometimes it's going directly to dietitians, sometimes the diabetes specialist nurses. But I'm doing that also whilst looking at System 1 to see what kind of input the patient has had in the past. So it's using that information to target the actual next step in their care. And so by being paperless within the diabetes clinic, it has meant that over the years, we've put less demands on the admin staff. So they're really grateful for that. And then something that we'd only use in a very limited way, but we decided to use in a big way when this all started, was to do a massive mail shot. So within System 1, you can run whatever report you like. So for instance, I said, tell me all the people with type 1 diabetes in Sheffield. And we wrote to them with sick day rules and also said, have you got a functioning ketone meter? And 300 people phoned our helpline and said, no, I haven't got a functioning ketone meter. And so the admin staff were very busy sending out lots of meters for us. We also wrote to other people that had been under our care and gave them specific advice. So there was different sick day rules for those with type 2 diabetes on insulin and those on different tablets. But all this was done just by running reports within System 1 and running something called hybrid mail. So it didn't mean that the admin staff had to print off these letters. It was just automatically and sent out. And the Foot Clinic did a very similar thing for their patients. I'm going to talk more about the Foot Clinic in a moment. You may or may not, I didn't see people from Sheffield actually joining the meeting, but this is Sheffield Arena in the top right-hand corner. So obviously it's very, very famous, and I understand Oasis played there about 15 years ago. But more recently, we're home to Arctic Monkeys, so I think probably they're the only band that sell out straight away in Sheffield. But that's what it's normally used for, and then all of a sudden, obviously it can't be used for mass gatherings. And so along with the City Council, the heads of the trust here in Sheffield said, well, actually, we need somewhere where people can get blood tests taken safely. And so they set up this drive-through service. And initially, there were 5 lanes, and now there's 7 lanes. So in this tent, you're directed into a lane, and you keep the windows wound up until you're called to the front of the queue. And then somebody in PPE gear comes towards you, you wind down the window, you stick out the best arm for taking blood, they take blood, and you drive away. So we send them out a patient leaflet to explain all about that. From my point of view, it's been really good. I've not had to explain to one patient where Sheffield Arena is. It's just on the outskirts, so it's good because it means they don't have to come directly into the middle of the city. And as a consultant or the nursing team who work with me would request bloods under my name and just need to state that it's going to be done by the drive-through service. They can attend Monday to Friday, 9 till 5. There's no appointment required. They just need to try to guess when the quiet time is. And those results are processed in just the same way. And because my name's attached to them, then I get to see the results on my patients as I would do normally in ICE, and I can write to the patient with the result. So initially, this was set up more for cancer patients and those on chemotherapy and the like. Very quickly, we realized that patients really quite liked this and felt safe doing this. For some of them, it's been their first trip out, actually going to get their HbA1c checked, and it's been a positive experience. So we're looking to build on something like this moving forward and looking for other localities around the city. And as I said, the patients seem to have really taken to it and have told me that it's been very quick and easy. In terms of pump upgrades, I think like the rest of the country, we suddenly went, oh dear, we should have upgraded some of these patients earlier. But it is still possible to do this in a safe way. It does need some pre-planning, and you do need to pick your patients properly. So for some patients, it is really straightforward. There's no obstacles. You can send them a new pump, and they will just switch over the settings from the old pump into the new pump, and you can be confident that there's not going to be a problem. But if you pick the wrong patient, then you can end up tying yourself in knots, and it can take quite some untangling as to which settings within the pump that they've got wrong. So it is a bit of a balancing act of the risk of not seeing somebody face-to-face or the time that requires versus them not having the correct settings within the pump. Now, lots of the pump companies are now very much on board. They've all extended their warranties for 6 months, which has been really helpful. And they are producing more and more videos to help support patients in actually setting up a pump. I'm part of the DTN committee, which is the technology committee for the UK. And nobody as yet has, I think, started somebody on a pump from pens, but lots of people are doing switches by using these supportive materials. And some of the reps are also saying, look, if you want me to be on the Skype, FaceTime, whatever you're using, then we've had nurses actually in that call, and then after a time, once they know the settings are okay, the nurse has got on and doing another job, but the rep is then talking perhaps through some of the advanced features on the pump that people were not aware of. But for some people, I think we still have to recognise that whenever you upgrade a pump or it comes to the end of its warranty, it is a time to think, actually, is this the right pump for this patient? Do they need to change perhaps from a tethered pump to a patch pump or vice versa? And one patient, in fact, this week said, actually, I think it's time I came off a pump. I've not really got out of it what I thought. Please, will you support me back onto pens? So it is really just keeping a very open mind about what the next step is and making sure that you make a really individualized decision about that. I mentioned the foot clinic, and obviously we're all trying to juggle risk in the best way that we can. And this is just an example letter. I've taken out the actual phone number and email address so as not to cause any confusion later when this is shared with your colleagues. But giving them a letter just to say, actually, we are still doing face-to-face clinics, because obviously in the media things seem to get shut down, and then we know that there'll be some people who should access healthcare who haven't. And so the foot team were very clear in saying, what do you do if, and have you got redness, have you got some antibiotics, have you got your dressings sorted? And there's various different numbers and email addresses within that. But our foot clinics, I guess like a lot of foot clinics up and down the country, were absolutely bursting to the seams at the time when lockdown came. And the specialist clinics are still running. But for some people, we said, actually, let's go and see them. So we've got a podiatry manager who was very good and very on the ball with a good plan very early on. And he recognised that we needed to support the district nurses and that they were likely to drop in numbers very quickly. So instead of some of the routine foot care that the community team were doing in terms of nail care or assessing high-risk feet, he said, actually, I need you to go and change the dressings that normally the district nurses would do. So they were doing that. And then they would contact their podiatry colleagues that were more specialists in the diabetic foot and say, actually, I don't like the look of this foot. Would you mind coming out and having a look? And so sometimes the patient then would be brought back into the specialist clinic. But quite often it was actually a case of, can you just take a photo of that for me and email it back? So we've got a separate email address where the community podiatrist can send up-to-date photographs of the wound. And indeed, patients were able to, some of them, take photos themselves, or maybe their spouse or partner or somebody in the household could take a photo for them and send that in. So we've encouraged photographs because it's quite easy and they're really high quality. So with all this, again, trying to just manage the risk, it's about having quick access back into the specialist clinic, but whilst encouraging as many people to stay at home if that's safe for them without coming to the foot clinic directly, and really just about being very flexible in their approach. And for some patients, we know, in fact, this has been quite a good time in that they have rested, they've stayed at home, and so some of the ulcers have healed, whereas obviously some people have needed more urgent action. And so finally, I just wanted to spend a few moments just discussing what Daphne has tried to do to support patients. So this is the education course that is more widely run across the UK, in all 4 nations as well. And for the last 2 or 3 years, we've been working collaboratively with the Open University, delivering high quality education for the actual educators. So the idea was to have less face-to-face training of Daphne educators, and for the Daphne educators to do most of their learning online about the Daphne curriculum, and then the face-to-face training within Daphne is about group management and facilitation skills and things like that. So we've been doing that for a couple of years, and in January, when we had one of our routine meetings, we did say we really need to develop this for patients, not knowing what was coming just in a few weeks' time. So we ended up speeding up all our plans, and so remote Daphne is going to be trialled next month. And what our national team have been doing is being very busy changing the online learning that we use for HCPs and making it very patient friendly, taking some things out, putting extra videos in and things like that. And it is designed to be done independently, but with a definite timetable. So, and on top of that, we know that the patients do gain a lot by attending Daphne in a group setting. So to recreate that, we're going to train our educators into how to do group activities on things like Zoom or Microsoft Teams or whichever media their trust allows. And we hope that by having this closed community, that people will feel safe and share their diaries, even if they're not in the same room. So it is self-directed learning, which promotes independence, but also allows people to access the learning flexibly, and they can go back and look at some of the more challenging bits of the course if that's what they want, or revisit links to sick day rules or things like that. And it allows them to self-pace. So they might decide to do it all on a Tuesday evening one week, or a different day another week, from the comfort of their own homes. And so I imagine that some patients will actually share some of this learning with their nearest and dearest in a way that perhaps might not have been possible before. So there are some definite positives from this that could be gained. This isn't done totally independently. It's done with the Daphne Educator clinical experience. So there's a timetable. It's based on the 5-week course. So each week they will be asked to do a module online at the beginning of the week, and then towards the end of the week, there's some planned group sessions, but also some one-to-one support if that's what individuals need, so that they can double check their learning and apply the principles to their own individual blood glucose readings. So they get the advantage that they get some immediate feedback in terms of fun quizzes within the online learning, but also timely support, not only from the educators, but hopefully from each other as well. And that shared experience, learning over the 5-week period, we hope will produce similar results as to the face-to-face learning that we've gained over the years. So this is going live from the 20th of July. Out of the 75 centres up and down the country, we have 40 centres that are signed up, and they all want to be involved in our pilot. So from the end of July, we have 300 patients in a 3-week period that are going to go through this. And we've carefully designed it, so we hope that that pilot will very quickly be able to share with the rest of the country. So, as I'm sure you've heard, that these last few weeks have been very challenging for all of us, but it is quite interesting. Things that I was told within my trust were impossible have suddenly become possible, and I think it's up to all of us to, if we can, got any spare energy left over, to really think what else can we change, because now is the time for innovation and acceleration in diabetes care. Thank you for your attention. I'm very happy to take any questions, and over to Hope.
Hi Jackie, thank you so much for sharing that. That was really interesting. Becky, if I could invite you back on the screen as well, and if anybody has any questions for Jackie or Becky, please do put them in the Q&A box. We have one which said, "Great talk, thank you very much. Please can you tell me if you have any experience with Tirecall?"
Tirecall. My experience with Tirecall is really limited. I do a transition clinic with the paediatricians, and I know that some of their, particularly Medtronic pump users, have been using that. And I think it's good. I think it's good to have another player in the arena that's really trying to drive things forward. So when I saw it, I could see that there were some advantages to it, some disadvantages, but I think it's up to individual trust whether they want to use something that is created by patients and perhaps has a bit less regulation around it. So it's really individual as to whether you want to use non-approved things. But I think they do have a place.
Cool. So someone's written in the chat, what platform will be used to deliver Daphne Virtual, and how do you overcome different trusts' differing IG requirements?
Okay, So we can't pretend to be technical experts. So it's Central Daphne. We have, I'm trying to think, we have 4 full-time members and 3 part-time admin. So, and it also is based in Northumbria. So it depends what systems they've got. So in Northumbria, where the central office is, they've got a free use of Microsoft Teams, which is, you know, has been made free to the NHS. And so we're developing instructions, SOPs as they're called, to help people use Microsoft Teams. In my experience, limited, it's growing. I think this is now my 4th Zoom call. So Zoom, I'm lying, I've done 2 Pilates classes, 6. So my Zoom experience is going up. I've also used Google Meet. I've used Microsoft Teams. They all work in a very similar way. So we're hoping that whatever your trust chooses, and my particular trust is going to use anytime, anywhere, apparently. I don't know how to use that yet. That you won't need to tweak these instructions too much. But, you know, we'll send you hard copies. You can just write, well, actually, with this system, we need to do X or Y. But we're not expecting people to be brilliant at it. I think, you know, as an experience as I've managed to get most of my diabetes nurses using Microsoft Teams, and, you know, they quite like it, and you do get upskilled very quickly. So, yeah, the first couple of times won't be as easy as follow-on times, but as long as patients have got at least a tablet, I don't think you could run Daphne groups off a mobile phone very well, but you can certainly run it off tablets or a PC.
Great, thank you. So someone on the Daphne topic, someone's asked how people can enrol in Daphne Virtual.
Okay, so within the centres, if you're in a Daphne centre, then you just need to let your Daphne centre know that that's something you'd like to do. As I've said, over half the centres, we were looking for 15 pilot sites, and now we've got 40. And you know, that's the great thing about things online, is that you can quickly upscale it. It doesn't matter if there's, you know, 10 people on this call or 100. So a lot of the centres will be in this first rollout, and then, you know, we don't expect there to be really a delay moving forward. The OU have worked really hard with this to adapt this learning very quickly. For people that are not in a Daphne centre, which I know was one of Becky's questions to me, and we've got a meeting, I think, booked for next week or the week after, we're just beginning to think about that, because literally we're just trying to keep one step ahead. But I think there's a definite place for it, because we know that Daphne works best if you're actually supported with your own glucose readings. So my prejudice is that if you just did the online learning alone, it wouldn't be as good a result as having the support of a Daphne educator, nurse or dietitian. So, but if you were living, let's say, in rural Lincolnshire and thought, well, actually, I could access the team at Sheffield, then I agree. Why can't I deliver, or, you know, ask my staff to deliver a course to somebody in Lincolnshire? So we're just beginning to think about how we actually do that for people that aren't very close to a Daphne centre. So can you give me a couple of months just so we can get the pilot run out? So it'll be the end of August by the time that the first people have done the first 5 weeks, and we need to make sure that people actually like what we've done. But it is definitely something that we want to pursue. And we want to hear, we want to hear from centres. If you're in a centre that's not a Daphne centre, if you go back on the last slide, there is our email address. Do email us if you're interested in becoming Daphne centre, or if you're in a centre where you think, actually, I'm interested, I'm not sure if everybody else is, we can just send you more information and open up that conversation.
That's great, thank you. Still on the Daphne topic, someone has asked a question about technology and how you can ensure that all participants have access to the technology.
So I agree. I think Sheffield's quite an interesting city in that when you look at the social deprivation, we have a bit of a U-curve. So we have more than our share of well-to-do people to universities or hospital. We have more than our share of poorer people. So it is very much a U-shape. And I'm very keen that we don't make the divide even bigger across Sheffield and across the UK. So I think, and when we were setting this up, we were saying, actually, you could do everything as a group, but there might just be people that want to do this over the phone. So they might have a tablet, but it totally freaks them out, the idea of joining a Zoom meeting. But if they did the online learning and had a phone call twice a week, for instance, to talk through all their individual readings, then I think that would still work. Because I, like you, don't want to put anybody off from accessing the help. And tablets themselves are relatively cheap now, aren't they? It's whether you've got a good Wi-Fi connection at home, or one of your relatives has. So we're saying that we do want as many people as possible to join in the group aspect of it, but it probably won't be possible for all. So we agree with that. We recognise that as limitation.
Yeah, perfect. So someone has asked, how did you fund the phlebotomy staff for the Drivethru blood tests?
I don't know, but it's working really well. So no, initially it was done through our trust. So it was just our chief exec, somebody must have given her the idea and she said yes. And more recently, because it's various, I don't know how it worked in other cities, but various things were gifted to us. So like parking. So in Sheffield, or the Sheffield City Council said, oh, your staff can park for free and stuff like that. And all of a sudden they seem to say, oh, you can have Sheffield Arena, for a knockdown price. So the actual phlebotomy staff are hospital staff. We said, do you like the great outdoors? Sometimes it'll be warmer than others. And we're asking for volunteers now to actually steward some of the traffic. But we've also said to the CCG that this has proven very popular with patients. How do we move this forward? And would you mind now finding some of your funds to help pay for this? Because we were doing bloods on hospital patients. There's lots of patients out in the community that don't come to hospital, but they still need their blood tests. So that conversation has started, but I'm not the finance person. I'm just, we've shown that it works. If you Google it, it was on the BBC website. You can tell your local people, look, it does work. Patients like it. Can we do something like that? But if anybody's interested, I will have to try and dig out who actually made it happen.
Yeah, that's great. We've got a few questions around that, so people are very interested about the funding.
Yeah.
So someone's asked, would you recommend GP practices would you recommend what GP practices should do with regards to annual checking of foot pulse, and if they were to consider diabetic remote reviews?
I don't have all the answers, and there's one of the quandaries that I've got. So I think with the best will in the world, not all the components of the 9 care processes will get done as well this year as they were done in previous years. But I think it's about making the most of every contact that you do have with the patient. So for instance, we have an eye screening manager here who's very proactive. And so he said, oh, nationally, I'm allowed to screen anybody that's got referable retinopathy. So I think this is still the same up and down the country. I don't think I'm saying anything out of turn. And so we said, okay, well, on Tuesday, we seem to have enough spare staff. So on a Tuesday, half-hour slot, 17 slots are for people that have referable retinopathy or who are pregnant and need to be screened more often. So I learned about that on a Friday morning. We had a list arrive Friday lunchtime for Tuesday. Friday lunchtime, I spoke to the podiatrist and said, look, these are high-risk patients because we already know they've got some degree of retinopathy. Have you got any spare staff to examine their feet? And she kind of looked at me sideways and in an hour came back and said, Jackie, it's sorted, we'll do that. And then the first week or two, I spent time requesting all their annual review bloods. And then, of course, I've delegated that to somebody else, thankfully. And so the outpatient team now know how, and they've been allowed to request bloods, whereas they weren't before. So the people that are turning up for an eye screen, we're politely asking them to take their socks and shoes off, have their blood pressure done, get their bloods done, and provide a urine sample. And I think we need to be thinking more and more about this, about how can we possibly do this, because I can't think that the patients that I've been reviewing in the last few weeks, that we're ever going to quite catch up enough this calendar year for me to invite them back to have their foot checks. But we just need to let them know, actually, your feet are obviously very important, and if you do have any concerns, then this is how you access help. But you've got to risk stratify your patients, and those that you already know at high risk, those are the ones that you're going to need to screen. Eye screening wise, it might be that people that had totally normal eye screening don't get offered eye screening this coming year. So that's one of the things that they're considering, just to try and play catch up so that we do screen those that need to be screened.
Okay, that's great.
Sorry, it was a long answer.
Oh, this isn't a question, but more of a comment. Someone's said that they're using Near Me /Attend Anywhere, and they can share the meter upload from DISEND and leave a review with the patient, and that is very useful. Yeah.
So you can share screens as we are doing here. So either leave review or DISEND. We've been asked in our trust, it's a massive trust, so they said basically who desperately needs video consultations. So diabetes has come a little bit further down the list, you know, compared to surgeons who need to look at wounds, for instance. And so at the minute we're mostly doing telephone, but even that works quite well, because DISEND will open up on the same page and you say, you know, are you looking at the logbook? What can you see? They've changed their colours recently if you haven't been on. So where are the red ones? Can you see if there's a pattern? So you can gauge where somebody actually looking at the same page as you. And similarly with Libre data as well, it works really well.
That's great. So if anyone has any more questions, please do keep sending them in. We've got about 10 more minutes to answer some questions. Someone has asked another question about the Drivethru blood clinics, and you know if there's going to be anywhere else.
So
will there be any Drivethru blood clinics elsewhere? So
for Sheffield, we're looking at places, hubs. So we're trying to we run some community diabetes clinics out of some of the sports centres in Sheffield. So we've been doing that for the last about 5 years. And so we're exploring, can we actually do some drive-through bloods there? Basically, you need quite a big car park, don't you, in order to set this kind of thing up. And then some reception staff. And we have various phlebotomists that actually would rather not be in the hospital, but decrease their risk by going to work at the arena. So as I said, we're starting to expand it, but I haven't heard any definite yeses yet. But it just makes so much sense, because the patients have taken to it. They, you know, understand the need to basically stay away from the hospital unless they are unwell. A more local problem perhaps is, since Boris said that all parking is free to STH staff, it's very difficult for patients to find a parking space until we move some of the staff off site. So, you know, there are some very practical reasons as to why that makes sense. And just to say, we've also asked the CCG, actually, why don't you do the blood pressure and the weight of these people? So it could just be a one-way system, that you have their weights, their blood pressure, their eye screening, and their bloods. You know, for diabetes, it could just be a walkthrough and then an appointment with myself, you know, a week or two later to actually discuss all the results. That's what we'd really like. That's what we've asked for. We haven't got it yet. If you don't ask, you don't get, because what was impossible before might now just be possible.
Yeah, absolutely. Someone has asked if you've explored the possibility of using postal bloods, so finger pricking samples.
Yeah, we haven't, but the paediatricians have. So There are various companies doing this, and there is a cost. And I'll let you then source the best deal. For one of our research projects, we did that, and we got in quite early, so we were quoted £5 a time, and apparently somebody else went in and well, now it's 20. So you do need to shop around, but the paediatricians are doing that, so you can do HbA1cs off capillary bloods and a blood spot. I myself have not looked at the data to see how accurate it is, but it must be fairly accurate, and you know it will be regulated, so the data will be there, and I think it is in this risk-benefit situation that we're in. I do think certainly we've had some patients that have engaged with us and have been more keen to get their glucose levels on average lower than they were previously, and some of them have had more time on their hands as well, so it is an opportune time for some people to actually get them to think about their diabetes more and take a bit more responsibility. Some people are obviously struggling, and you know, I'm not trying to say this is for all patients. Some people have ended up with a lot more caring responsibilities, and life has become more difficult for them, so they've got less time. It's just trying to pick those where you do have an opportunity to improve things if you can.
That's great, thank you. Someone has asked about the presentation being made available, and I can answer that one. We have recorded this webinar and it will be uploaded to our YouTube channel by the end of the week, so that you can catch up and rewatch it if you've missed parts of it as well. So next question is, the technical side of glucose management and of screening is developing very well, but anxiety and distress levels are also increased in people with diabetes. How do you ensure that the emotional side of living with diabetes is not overlooked as the technology takes over?
Okay, I like to think that I'm a bit of a technology skeptic, so I have two hats. So I lead the pump service in Sheffield, but then I don't think pumps are for everybody. And I think, you know, technology definitely has its place. Libras are really good, Dexcom's really good, but are they for everybody? Probably not. And whatever system that you're on, you're right, you do have to manage the emotional aspects of that, because if you ignore that, then you don't make any progress. And so we have various systems where IAPT is online. So IAPT locally, we have Sheffield are very lucky that we had quite a good service, and a lot of that was face-to-face, but some of it was online. And so we've had to encourage people to go online if they can. Some people have formed WhatsApp groups. Our local patient group is actually more active than it has been. So people are accessing that, and we're trying to publicise that, because I think you're right, the actual lived experience of diabetes is so very personal that some people will gain a lot by being part of a peer group with other people with diabetes, definitely.
Absolutely. Someone's just written a comment about the finger pricking question, and they've written that capillary HbA1c is accurate, and we do use it in our paediatric clinic regularly. We have backup with annual control with lab as well. Okay.
Can you ask them how much it is? Or can they post us how much it is, just for everybody's interest? I asked our lab manager how much a routine HbA1c was last year, and was pleasantly surprised that it was 35p. So I don't know if we can have some kind of comparison from that person is.
We'll look out for the response.
Okay.
I'll let you know. So someone else has asked, where we can't get the blood test done easily, do you use the estimated HbA1c from LibreView?
Yes, I think it's definitely within the right ballpark, because it uses an equation derived from the DCCT study, so that, you know, fairly decent study. It's occasionally you can have a bad sensor. in that it's not accurate, so it can make your HbA1c look very good or very poor. But I think it definitely does give you a good idea, and also more often than not, I do write down the estimated time in range, because that, once you get used to using time in range, then that does give you a good idea of the HbA1c. And I think it's looking at the two together, same as with any HbA1c, a result of 55 is only good if you're not hypering all the time. So I'm trying to encourage everybody here to write down the amount of time less than 4, as well as 4 to 10, and the estimated, so that you've got all 3 components to examine.
Okay.
But yeah, I think it's reliable enough if you can't get a test.
Yeah, that's great. Thank you. Someone's also asked, would you recommend foot check being done remotely?
I guess it's who's doing it. So if you've got enough community podiatry to do that, you can always look at feet. As I said, we don't have video consults set up for people to show off their feet to me when I'm doing my clinic. It doesn't really tell you about sensational pulses, does it? So, and I think that's quite difficult. So if you're really worried, then I think you ought to be having trained staff actually doing the foot checks.
Okay, that's great. Thank you.
But you know, family members have always been good at looking at feet. Some people physically cannot look at the bottom of their feet, and not everybody has one of those nice face mirrors to put on the floor and then wave their foot above it. So yeah, do make use of other family members to look at feet of your patients.
That's a good tip. Thank you. So that's it on the questions. Either Becky or Jackie, do you have any kind of final comments or things that you'd like to share before we sign off today's webinar?
No, I just wanted to say thank you to Becky. I didn't know about that online resource, so I will double check that the Sheffield team here are well aware, and it's really good that, you know, as a whole, that all the companies have been very helpful in, you know, sharing as many materials as they can. And I think, you know, we definitely appreciate this kind of openness to share good practice. So thank you.
Perfect. Well, thank you very much. We can see the comments of thanks coming in now saying that they really enjoyed the presentations.